Hello and welcome to the live press conference where we'll provide an update on COVID-19. I am your host, Fennel Neptune. Today we have with us the panel, who is the Chief Medical Officer, Dr. Sharon Belma George, also the National Epidemiologist, Dr. Michelle Kassois, and the Assistant Principal Nursing Officer, who is also the National Immunization Manager, Nurse Tekla Jabatis. Today, we will be having each person giving us a brief update on different areas. We are live via the National Television Network and also the Government of St. Lucia's Facebook page and YouTube channel. First, I now call on the National Epidemiologist, Dr. Michelle Kassois, to provide us with a COVID-19 situation update and also speak on the reclassification of COVID-19 deaths.
Thank you, Ms. Neptune. Good morning, St. Lucia. Globally, the numbers of new cases in the past week has been close to 2.6 million, which has been a similar trend in the previous week. The weekly deaths have decreased somewhat, 10% compared to the previous week. And however, the incidence of COVID-19 worldwide remains high, with almost 370,000 cases being reported daily over the last week. The total number of cases worldwide has been over 180 million cases, with the Caribbean experiencing close to 1 million cases. And within the CARPHA member states, 216,000 cases. Can I have the slides, please?
The presentation slide, please.
In St. Lucia, we have had 5,326 confirmed cases of COVID-19, with 165 of these cases being reported in the last 28 days. We have had 41 variants. These variants have been the Alpha, or what was formerly known as the British variant. So we have not noted any other variants in St. Lucia to date. However, we continue to monitor the situation regionally where we note the presence of different variants. Our COVID-19 deaths, the combination of COVID-19 deaths and COVID-19 related deaths, have been 85. Over the past 7 days, we have averaged 4 cases daily, with a daily infection rate of 2.2 per 100,000, which is less than the previous 7 days where we had 4.9 per 100,000 population. The total number of tests to date as of the 5th of July 2021 has been 54,069 tests with an average test positivity of 4%. When we look at the distribution of cases by age group and sex, we've noticed that there has been an almost equal split, male-female. However, our age group, 25 to 49, continues to be the age group that has been most affected, with 53% of all the cases being in this particular age group. However, the ages have ranged from 11 days to 103 years. When we look at in terms of our school population, we know that about 10% of the cases have been in the school age. And let me stick a pin in there because this is what is reported nationally, internationally, regionally. I would like to recognize the work of the Ministry of Education as well as our contact tracing team, because together with that close association, we have managed to ensure that school has run smoothly this term. We have managed to ensure that the students remain at school without shutting down schools, and we have had minimal transmission in classrooms to date. So the children, while we did expect cases, we do have community transmission, and it is only natural that persons, the students, would have gotten COVID-19 from parents, from neighbors, from friends. We have managed to keep the in-school transmission to a minimum and have school continue throughout the term. The children wrote their exams, and we are quite pleased with that level of collaboration between the Ministry of Education as well as the Ministry of Health. In terms of districts, we note that Babonokon continues to be the most affected in terms of health regions in St. Lucia. followed by ancillary, grocery, Castries. And while the number of cases in Castries has been higher than the other health regions, we plot here the incidence or the rates, because although the number of cases are more, but Castries would have a significantly larger population compared to Babonneau, and therefore the rates would have been higher in Babonneau compared to Castries. So just a little clarification for persons who are currently viewing the graph. In terms of distribution by months, we note that from the onset, our first case detected in March 2020, our peak has been in January and February, which was post the Christmas celebration, and that has been a trend that has been noted throughout the world. Persons let down their guards during that period, where there were family parties, staff parties, etc. And so we saw the results in January as well as in February. We have continued March, April through to June, recording cases and trying to keep them at a level which does not overwhelm our healthcare system, but cognizant of the fact that there is still local transmission and that the public health measures still need to be reinforced. When we look at our epi curve, we note, as previously indicated, that January and February were our peak months. We have noted little spikes throughout the months, and given the presence of variants, we are cognizant of the fact that we may experience a larger outbreak. The different variants have been proven to be more transmissible, and so we are very wary that we have neighboring countries with the different variants, and so although our numbers have gone down, we are still monitoring what is happening on the ground in order to avoid an overwhelming surge of cases on our public health system. In terms of deaths, males account for 71% of all COVID-19 deaths and COVID-related deaths. The age group most affected would be our 60 plus, and we have noted that in approximately 70% of the deaths, they had been diagnosed with either diabetes, high blood pressure, or a combination of the two at the time of their deaths. So I will stick a pin in the death issue and talk a little more about the exercise which we undertook last month. So in St. Lucia, we had been reporting COVID-19 mortality, and it included every single patient who tested positive for COVID-19 at the time of their death and tested by PCR. However, we have local, regional, as well as international reporting requirements. COVID has been proven to be quite a fluid situation. A lot is still being found out about COVID-19. The novelty of it all has overwhelmed us in terms of transmission, vaccination, etc. And one of the things that we have noted is that while some countries report the combination, as we had been doing, other countries report only deaths due to COVID-19. So the exercise conducted to reclassify the deaths was really undertaken to ensure that when the need arises and when we do have international partners or regional partners who request that information, it is readily available. So to understand fully the exercise, I will go into a little definition of what exactly this COVID death is. So when we talk about death due to COVID, we are speaking of an individual who presents with the clinical illness, which is compatible with COVID-19, and unless there is a clear alternative cause, which is not related to COVID-19. So in the case of trauma, an individual who happens to, for whatever reason, a homicide, and at the time of his death is diagnosed with COVID or tests positive for COVID-19, this individual would not be classified as a death due to COVID. His death would have been the result of the trauma, whatever homicide, be it gunshot injury or stab wound, whatever. Also, there should be no period of recovery from COVID-19 between the illness and death. So if an individual tests positive for COVID-19 and 2 months down the line he dies, he or she passes away, that individual did not pass away because he made a full recovery, so he did not pass away due to COVID-19. And similarly, there should be no attributed other illness such as cancer. So an individual who has terminal cancer, for example, and passes away and happens to test positive for whatever reason, be it that he was requiring surgical intervention and a routine COVID-19 test was done, and he tested positive, he or she tested positive, that individual would not be counted as a death due to COVID-19. So these deaths that I described would be termed as COVID-related deaths. They were not the underlying cause of illness. And what we had to do in terms of this classification, let me have St. Lucia to rest assured that the death certificates were not modified. Nothing was changed. At the Ministry of Health and Wellness, we do not sign death certificates. What we do is review the death certificates. So based on the chronology of events which the attending physician had documented on the death certificates, we use this to determine whether it was a COVID death or a COVID-related death. And so, for example, an individual in the cause of death on a death certificate, an individual who tests positive for COVID-19 may develop a pneumonia, and that pneumonia may lead to acute respiratory distress syndrome. And that would be classified as a COVID-19 death. Similarly, as I explained, an individual who, for example, has a heart attack, that would weaken the heart and cause some sort of heart failure. And so this individual testing positive for COVID-19, and if you notice, COVID-19 is written in part 2, and there are 2 parts to this death certificate. So that individual would not be classified as a COVID-19 death because his underlying illness was the heart attack, and which led to heart failure and the resulting death. So this was the exercise which we conducted in order to reclassify the COVID-19 deaths, and it was done mainly for reporting purposes at the level local, regional, as well as international level. What we also did during this process is that we did a data cleaning process of our database. Now, anybody who manages a database would understand that databases need to be examined, they need to be cleaned. There may be duplicates, and it is very easy to get duplicates in a database, whereby persons may present using their driver's license, for example, and present at the hospital using their national ID card. And we know on death certificates, sometimes you know somebody by one name and they present with a totally different name later on. So all of these issues we had to address, go through our database to ensure that the information that was there was reliable. We also took that opportunity to also update our database for missing fields. Now, in the unit, what we do is both active and passive surveillance. So through the passive surveillance, we receive reports of deaths in the community from the physicians, and COVID is a reportable disease. So we would get that information from them. However, there is also what we call active surveillance, whereby we go out. So in addition to persons sending in that information, we also go to the reporting facilities, to the respiratory clinic, to the morgue, etc., to look for death certificates, to look through the books, to try to identify any other individuals that we may have missed and should be added to our database. So we did all of these processes last month in order to update our database and to ensure that we had the most reliable data possible. And so from that review, we now have 60 COVID-19 deaths. So these are deaths due to COVID-19, and 25 COVID-19 related deaths. So these are the deaths. An individual who would have died would have tested positive for COVID-19, but died of another cause. And although we have heard quite often that COVID-19 predisposes individuals to clots, we have to be cognizant that in St. Lucia, NCDs, or non-communicable diseases, have been the leading cause of death in St. Lucia for some time now. And so it is not out of the ordinary that we would have persons dying of heart attacks or of strokes. And the mere fact that we have community transmission of COVID-19, we would still expect persons to be dying of strokes or heart attacks and happen to have COVID-19, and with COVID not being the cause for their death. So I will hand over to Dr. Belma, who will go a little more in detail and speak of our variants and our public health measures to date. Thank you.
Thank you very much, Dr. Kaswa. I now call on Dr. Sharon Belma-George to speak on the new protocols and adherence. Also, she will be focusing on the variants of COVID-19.
Thank you very much, Ms. Neptune. So St. Lucia, together with the rest of the region, has continued the phased reopening of the country within the month of June 2021. This safe reopening has required a careful balance between the reduction of the restrictive measures and the strengthening of the other public health measures to reduce the importation and spread of new cases. Some of the new protocols that have been implemented include the exemption of quarantine for fully vaccinated travelers. And I really want to take a moment to define what fully vaccination, being fully vaccinated means. People are considered fully vaccinated for COVID-19 over 2 weeks after they have received the second dose in a 2-dose series, or over 2 weeks after they've received a single-dose vaccine such as the Johnson & Johnson. So we want to ensure that everyone is very clear on this as we keep noting persons are coming in soon after taking the vaccine and not fitting the criteria of being fully vaccinated. We also want to remind all travelers that even if you have your negative test and you're fully vaccinated, that you have to still apply for authorization more than 7 days in advance of travel. And that gives us a chance because you need to upload your negative test. You also need to upload your vaccination card. And for those who are requesting home quarantine online, it gives us a chance to do the examination of the home for approval. So it's really important that you still apply. We've been getting a lot of complaints of persons who just buy a ticket and go to the airport. You need the authorization. We are trying as much as possible to keep travel safe in terms of persons having a negative test and being fully vaccinated so that it'll be very easy when you come in. So we want to remind the public that even though you're fully vaccinated, if you're negative test, you have to apply on the site online more than 7 days before travel to allow all of your documents to be reviewed by the relevant authorities. We have also decided to remove the Caribbean bubble. The Caribbean bubble, we looked at the level of disease within the other islands, and for those who kept a certain level, we would allow them to come in without quarantine. The level of risk in the region has changed. We also note the presence of all 4 variants of concerns within some of the countries of the Caribbean bubble. So a decision was taken that the Caribbean bubble, the countries within the Caribbean bubble would fit into the same protocol for the rest of the world, where fully vaccinated persons come in without quarantine and everybody else who's not vaccinated would have to go through the quarantine process. A decision was also made to recommence the Martinique ferry effective July 1st. Also an increase in the number of social activities, and this is for fully vaccinated persons only, and there is an application form which has to be filled out and submitted 14 days before your activities to allow us to review the lists. Also for spectators for sporting events, and this as well is for fully vaccinated persons. Campaign protocols have also been put in place after consultation with the major stakeholders. So as much as possible, the campaigning that allow the different activities that are there will be done in a safer as compared to what has been happening previously. As the travel and social protocols are just said, we are still at high risk of introduction of those variants of concern. We note that 54% of the COFA member states are still reporting community spread, and all 4 of the variants of concern are present in the region. And we know that they spread faster, they cause more severe and a higher death rate as usual. We know that the WHO as well, they've updated their naming convention for the variants of concern using the Greek alphabet. So the alpha is the one which we call the UK variant, and this is the one which we've noted in St. Lucia. I also want to indicate that we continue sending samples to the Caribbean Public Health Agency for sequencing, and to date all of the results that we've got indicate the presence of the Alpha variant, which is the UK or the British variant. The beta one, which is identified in South Africa, Gamma in Brazil, and Delta variant from India. So these variants, they differ in relation to their level of transmissibility, the level of complications, hospitalizations, fatality rate, and also vaccine resistance. So just to give you an idea, can I get the slide up, the variants? As I indicated, the four main variants of concern that have been noted would be the Alpha variant, which was reported in December in the UK. It has been, from July 1st, it is noted worldwide in at least 172 of the WHO regions, and at least 41 in the Americas and 27 in the Caribbean. This is the one that we have and we've noted in St. Lucia. It's estimated to be 24 to 70% more transmissible than the original, with a higher viral load than the previous variants, and a possible 55% increase in the death rate. Now, this is the one which we have here, and we noted it during the spike which we had, the huge wave we had between January and February this year. The recent trials have shown some vaccines to be less effective, but not significantly, and the vaccines are likely still effective in controlling transmission and reducing severe disease and also death. So it's 66%. The AstraZeneca vaccine, which we have here, is 66% effective against the Alpha variant. The Beta variant, which is the South African variant, which was detected in May in South Africa, it is worldwide in the Americas and with 10 in the Caribbean. It accounts for 90% of the cases in South Africa. It is 20 to 30% more transmissible, and although there is no increase in severity, clinical disease, it accounts for over 20% of in-hospital and an increase in the mortality rate. And this is the variant, the South African or the Beta variant, which shows more resistance to the vaccine. So they're saying the vaccines are only 50 to 60% effective at preventing mild to moderate disease. The Gamma variant, which is the Brazil variant, which was detected from November 2020 in Brazil, it is also worldwide, and there have been 14 cases in the Caribbean of the Brazil variant. It is 29 to 48% more transmissible than the original, and it's responsible for over 85% of the sample cases in Brazil. It is also known for an increased risk of hospitalization. The vaccines do respond to the Brazil variant, and they are effective in controlling both transmission and reducing severe disease and death. The Delta variant, which was the one which was in October, noted in India, as of July 1st, in at least 96 in the 6 WHO regions, and there have been at least 8 within the Caribbean. And this is the one which is most feared at this point, because its a level of infectivity is the highest as compared to all of the others. It's over 55% more transmissible than the Alpha variant, which we noted here in January and February. It causes more severe disease, hospitalization, and deaths in the countries. But the good news is that the AstraZeneca vaccine is very effective against the Delta variant after taking your 2 doses. So the variant which we have the most concern for introduction in terms of the effectivity of our vaccine is the South African variant. So just to give a little idea of the various vaccines that are available, we note that the Alpha, the Gamma, and the Delta, these are those that fully vaccinated persons are still covered against hospitalization, severe disease, and also death. As we know that we are well into the second year of the COVID-19 pandemic, and the global situation still remains quite fragile. While on a global level, the trends in cases and deaths have been declining in recent weeks, there is significant variation by region and by country and within countries. Some countries are noticing sharp increases in cases and hospitalizations, and there are a number of factors that contribute to this. The emergence and circulation of more transmissible variants, the increased social mixing and mobility, the uneven and inequitable vaccination, and the considerable pressure to lift public health and social measures. So like I indicated earlier, the variants of concern, they increase in terms of transmissibility, and the Delta variant is expected to rapidly outcompete other variants and become the dominant variant over the coming months. So it is estimated, we know that the Delta variant is in the region, and we anticipate that when it does come in, we will get another spike in cases similar to what we managed with the British variant. The low vaccination coverage at a global level is another issue. While over 2.65 billion doses of the COVID-19 vaccines have been administered, the majority of those have been in a small number of high-income countries. The gap has been reduced with the use of the COVAX facility in ensuring that lower-income countries are able to get the vaccine, but the majority of the world's population still remains susceptible and at risk of developing COVID-19. The other issue which I mentioned was the increased social mixing and lifting of the public health and social measures. Countries have moved in and out of the restrictions, as we saw here in St. Lucia over the last few months, and there's considerable pressure to reduce the remaining public health measures and social measures. So we know social mixing and mobility, the increase in the number of gatherings, from friends to family to sporting activities, side events, religious celebrations, and these activities also increase the risk of transmission and allowing the virus to spread. So what we recommend is a comprehensive approach to controlling COVID-19, which includes the implementation and adjustment of the public health measures and social measures to suppress transmission and to reduce severe disease and death. So for us here, as those measures are reduced, it's imperative that we maintain our active surveillance, contact tracing and isolation. We continue community testing, maintaining physical distancing, wearing of the face mask, and the hygiene practices that have been advised. There is increasing evidence that persons with chronic diseases or compromised immune systems are at greater risk of developing complications of COVID-19 and death. So it is important that we also maintain a healthy lifestyle through diet, exercise, reduced stress, elimination of smoking, and reduced alcohol intake. Vaccination continues to remain the most effective public health measure in managing infectious diseases. The AstraZeneca vaccine has been proven to be safe and effective in protecting persons from developing COVID-19, its forms, complications, hospitalizations, and death. So we continue to urge the public to access the various sites to get immunized at the soonest and to encourage your family to get immunized. So we continue to advise the public. I indicated the risks that are still there and it's coming closer to us in the region in relation to the variants of concern. So it is important that as the measures are relaxed, we continue our hygiene measures of hand washing, use of the face mask, avoiding unnecessary crowds and persons with respiratory symptoms, and frequently touch surfaces, that we maintain hygiene at home and in public spaces. Thank you.
Thank you very much, Dr. Bilma. A very important part in terms of combating the COVID-19 pandemic is vaccination. I now call on Nurse Tekla Jabatis to speak on the COVID-19 vaccine. She'll speak on in terms of inventory, expiration, and also the benefits and our vaccination strategy in St. Lucia.
Thank you, Ms. Neptune, and good morning, St. Lucia. CMO, thank you for setting the tone for vaccination. So it's been about 19 weeks now since the introduction of the COVID-19 vaccine to our population. That's approximately just about 5 months ago. As of yesterday, the 5th of July, a total of 31,037 first doses and 22,152 second doses of the AstraZeneca vaccine has been administered. This accounts for 17.1% of the population being fully vaccinated and 12%, this accounts for 17.1% of the population being partially vaccinated with 1 dose of the vaccine and 12.2% of the population having received 2 doses of the vaccine. The past 5 months, of course, over the past 5 months, there have been frequent assessment and evaluation of the campaign strategy. All of that is in an effort to ensure uptake of the vaccine, especially by those who are at medium to high risk of contracting COVID. And we know these are the persons that would suffer the severe complications of the disease and the worst part being death. The campaign, of course, has transitioned from initially a phased approach to opening to the general population with the inclusion of mobile pop-up sites, all geared again towards accessibility and availability of the vaccines to persons in the population. We have also added one other component. Last week, a public-private partnership initiative was launched. The People's Discount Pharmacy has partnered with the Ministry of Health offering COVID-19 vaccines. This is the first of this kind in St. Lucia, where persons can access vaccines at their local pharmacy. We hope that we could extend this sort of service to other health providers in the near future, and that other pharmacies and other healthcare facilities, or providers rather, would be willing to offer vaccines to the public. Of course, we continue to offer vaccines at our routine static vaccination sites every week, island-wide. And of course, the focus on the elderly population, those persons at home with mobility challenges, we continue to reach out to them at homes, in their homes. The success of the achievement of the COVID-19 vaccination campaign so far would not be possible. And at this time, I just want to take the opportunity to acknowledge the efforts, the commitment, and the dedication of the entire health team, especially the core teams who are out there daily on the ground, ensuring that vaccines are accessible and available to the population. I will take this opportunity now to speak a little about the uptake. We continue to assess the uptake of the vaccine. We know that the highest uptake of the vaccine is noted amongst the over 50 years age group. This is followed by those 25 to 49 years, and the lowest being amongst persons 18 to 24 years. This pattern is consistent with both the first and the second doses of the vaccine. It is also noted that the second dose uptake is about 71% of that of the first dose, bearing in mind that we probably have approximately 14%, which is just about roughly 4,000 persons, 3,990 persons to date who are not yet due for their second shot, taking into consideration the 10 weeks interval between vaccines. But it has also been noted that we still have a significant amount of people, a significant proportion of persons, about 29% of persons who would have received their first dose, who have not taken their first dose of the vaccine, their second dose of the vaccine. In light of this, an appeal goes out to persons who have not taken their second dose of the vaccine to do so. Being partially vaccinated, of course, with 1 dose of the vaccine will not afford the full protection that the vaccine affords. And I'm happy that CMO really touched on the variants and I'm happy that she spoke about the effectiveness against the variant. And we realize that that protection is only if you are fully vaccinated. It is important for me to touch on our stock management of vaccines, as this has generated quite a bit of discussion over the past weeks. So far, St. Lucia has received 3 main shipments of vaccines, 2 of which were from the allocated number of doses through the COVAX facility. The other being the first donation of vaccines that St. Lucia received from the government of India. The allocation of vaccines from the COVAX facility intends to cover 20% of the population. The donation that we received from the Indian government would have only covered 5.5% of the population with 2 doses of vaccines. St. Lucia awaits the 3rd installment of vaccines from COVAX. This shipment has been delayed due to vaccine logistics, limited supply, etc. For the immunization program, it's not a significant concern, especially at a time when we note slow uptake of the vaccine. The spacing of the arrival of vaccine shipments to St. Lucia has allowed sufficient time for use of our stock before the next major shipment arrives in country. 2 of the previous batches of vaccines that we would have received had expiration dates of June 2021. As at the 30th of June 2021, there were no doses of vaccines from these batches left at our central stores. What this means is that whatever doses of these batches of vaccines that were still here would have been in circulation at the various health centers and vaccination sites, and these would have been used up to the last day of the vaccine shelf life, which is the expiration date. The remaining stock of vaccines at our central stores will expire in 2 months. The immunization program, and by extension, the Ministry of Health, continues to carefully plan its vaccine logistics to ensure that wastage is reduced or is at minimal when an expiration date comes, especially with vaccines that have very short shelf lives, such as the COVID-19 vaccine and also the influenza vaccines. The same holds for all other vaccines in the program. The program holds strongly to the first in, first out principle. What this means for us in the immunization program is that every effort is made to use up vaccines with earlier expiration dates first to avoid wastage. In some instances, it means collecting vaccines from facilities with excess stock on hand and redistribute amongst the facilities, especially to areas where the uptake is highest. Having said this, the 3rd installation of vaccines from COVAX is expected sometime late July into early August. So I'm saying all of this to explain the whole issue about expiring vaccines, which have brought so much discussion. To date, we have as at June 30th, we had no stock of the expired vaccines in our central stores. And in addition to that, no vaccines were disposed as would have been indicated. In addition, in terms of our procurement of vaccines, the Ministry of Health continues to make progress towards procuring other vaccines we have noted that there is a call. There's a demand for added vaccines, for other options of vaccines into the program. So as such, the ministry is making progress. We have engaged suppliers, reputable sources for procurement of the Pfizer vaccine and also the Johnson & Johnson vaccines to be included into our national immunization program. And any updates regarding these shipment of vaccines will be provided. Just a reminder, and I just want to emphasize that the immunization program, St. Lucia continues to rely on the World Health Organization for approval for vaccines. We need to ensure that safe and effective vaccines are introduced to the population. We know of the benefits of vaccines. CMO has touched on it. However, I think it is still important that I touch on the benefits. First and foremost, we know that vaccines protect us from the severe form and complications of the virus. It is important for persons, for a significant percentage of the population to be vaccinated. Failure to vaccinate enables circulation of viruses and, of course, generation of variants. And I'm happy CMO would have touched, on the variants. We know that economies are reopening, and of course restrictions are being lowered. And there's going to be a lot of social mixing and a lot of interaction. And of course that in itself puts or increases the risk of importation of COVID-19 cases and variants. We know that viruses are simple organisms that mutate quickly when they get favorable conditions to do so. Therefore, we need to be vaccinated. It is important. It is becoming increasingly important for us to get vaccinated. Of course, we know once a significant percentage of the population would have been vaccinated, of course it would allow for a return for normal social functioning and reopening, full reopening of the economy. Earlier, I would have mentioned about the lowest uptake in the younger section of the population, our 18 to 24. We know that younger adults, typically they are less clinically affected by COVID-19. And as a result, this may be contributing to the decision to get vaccinated. But we need to bear in mind that COVID-19 manifests and affects people differently. There is absolutely no guarantee that because you are young and vibrant and in supposedly good health, that if infected with the virus, that you will not become severely ill or suffer complications. In addition, we know young people, they move around more, there's more social mixing, and as such, we know these are the things that increases the risk of transmission of the virus. Not just to young people like themselves, but also to loved ones, to our elderly grandparents, and to persons that we interact with, which may have a chronic condition, putting them at risk. So in light of this, we continue to encourage persons to access vaccination to protect themselves, to protect their loved ones, and their communities at large. Thank you.
Thank you very much, Nurse Tekla Baptiste. We now will take a few questions from the public and also the media. Persons can call 468-2162, and it's also live via the National Television Network and the Government of St. Lucia's Facebook page and the YouTube channel. The first question we have is from Sheffield Gilead from Loop St. Lucia. The question is for CMO. What protocols are in place for general election, knowing that CMO said some time ago that there will be an increase in COVID cases post-elections?
Thank you very much, Ms. Neptune, for this question. looking at the range of activities that traditionally occur during the campaign period of elections, most of those activities are high-risk mass crowd activities where you have a lot of persons within a confined setting. And also looking at the precedents that has been set in the region post-general elections. Practically all of the countries noted a huge spike, and especially for us, when we look at where the risk areas for increasing cases are, it's those social activities. So what the Ministry of Health did in anticipation of the upcoming elections were to generate protocols, and the Environmental Health Unit worked very well in the preparation of those. I have to acknowledge them, looking at what and how activities happen on the ground. We put in, together with the Royal St. Lucia Police Force, taking into consideration that those activities generally, the permission is granted through the legislative process, through the police, the Commissioner of Police. So we were able to put together a draft to reduce transmission. They remain high-risk activities, but the protocols ensures that a framework is put into place to reduce the transmission. And these protocols, we did have a consultative process with the main stakeholders, and they did bring some very important points to allow us to tweak this protocol to reduce the impact. And some of the things are, traditionally there are very huge national campaign meetings. This is one of the activities that we are avoiding, and to instead have the meetings at the level of the constituency. We've also allowed the motorcades, but within a framework where you remain within your vehicle, to as much as possible reduce the large crowds that can be associated with it. And we've also limited the times as well to reduce the number of activities. So I think that was a very progressive meeting with the various stakeholders where they understood where the major risks are. The Ministry of Health at this point, we are planning and we do anticipate to get increasing cases with the increased activities on the ground. But we are hoping that this can be reduced as much as possible through the implementation of some of those protocols within the document that has been finally approved.
Thank you very much. We have a second question from Sheffield, from Loop St. Lucia. During the last press conference, you indicated that you had not processed the results of the vaccine hesitancy survey. Are you able to speak more about that now? What is the level of vaccine hesitancy in the population, and what new methods is the ministry exploring to counteract that?
The vaccine hesitancy? Okay, we continue to get vaccine hesitancy among the population and from various groups. And we have been listening to the population. Some persons have indicated that they would prefer, for example, to get the Cuban vaccine. And we have communicated, we have very good relations with the Cuban government. So as soon as it's gotten its approval for WHO, it's right now within phase 3 clinical trials, and there have been very positive results so far. So as soon as it gets through the WHO approval, this is one of the vaccines that we are going to make available. We had a very important consultation with the Rastafarian community, and they have indicated that this is one of the vaccines that they have greater trust in. So it is really, we really want to have it available once the WHO approval comes in. We are also working on getting the Pfizer and the Johnson & Johnson in country, so persons have a greater a range to choose from to increase our coverage in country. We get that hesitancy mostly among the younger age group, where persons believe we're strong, we're healthy, we're doing okay, we don't need it. But we are seeing supposedly strong and healthy persons also being impacted by COVID-19. So this is one of the groups that we have a lot of work to do. Now the vaccine, we've changed the approach that we were taking, increasing the number of community activities and on the ground. One of the things which we have increased is the work in the community, where we take the opportunity to listen to the concerns of the population. Some of them we can understand why. There's a lot of misinformation out there, and we've noted that once you take the time to, in a very simple way, clarify to the population why some of what they're believing is not true, we get an increase in the uptake. But because we have to do so many little groups among the community, it's more time consuming as compared to what we traditionally did for mass media.
Thank you very much. We have a question from Nelsha Charmaine from Choice TV. This question is for Dr. Faswad. She's asking if it's possible to provide clarification, to explain again the reclassification of the COVID-19 deaths.
Okay, thank you for that. If she has a question, I'm assuming there may be others out there, so I appreciate that. We reclassified, as I indicated, to meet our reporting requirements. And so we have what is considered a death due to COVID or COVID death, as well as a COVID-related death. In the case of a death due to COVID, the underlying cause would have been COVID-19 infection. So that would be an individual who would have come in, tested positive for COVID-19 with signs and symptoms, and would have progressed usually to a pneumonia or an infection of the lung, and which would lead to acute respiratory failure and the death of that individual. In classifying this individual as a death due to COVID-19, this individual should at no time have an underlying illness which could have competed or could have been attributed to his or her death. And there should have been no recovery period between the diagnosis and the death of that individual. So case in point, an individual testing positive, coming in, as I said, with pneumonia and dying, that would be classified as a COVID-19 death. A COVID-19 related death would have been an individual, for example, in a motor vehicle accident. That individual would have probably have hemorrhage or some underlying cause of death, which would have led to his death. At the time, during a procedure or whatever have you, that person would have been tested and come back COVID positive. That individual, because COVID-19 was not the cause of his death, in that COVID-19 did not lead to his exact death, he would be classified as a COVID-related death. So this is an individual who died and just happened to test positive for COVID-19, but COVID-19 was not the reason why that individual died.
Thank you very much. Lucia Baptiste, when you spoke earlier on, you mentioned about the disposing of the vaccines. And this is a question that one of the media reporters also had the question about. And if you could also state it again, whether or not St. Lucia disposed of any vaccines recently or at all.
Thank you. As I would have indicated earlier, leading up to, well, first off, I just want to re-emphasize that all vaccines have an expiration date. Yeah? 2 of our batches of vaccines that we would have received would have had expiration dates of June, end of June 2021. Again, I would say that the Ministry of Health, the vaccination program, carefully plans its vaccine logistics. And one of our top priorities in the program is to minimize wastage. So we would make every effort to ensure that vaccines are used up by that time. Of course, in our routine program, sometimes you have cases where you have no control over. But as with the case of COVID-19 vaccines, the Ministry of Health did undertake all strategies, revisited the strategy, knowing very well that we would have had that the batch of vaccines would have expired in June. As at the 30th of June, there were no vaccines in our central stores that would have been expiring on that day. the weeks leading up to the 30th, we would have distributed these vaccines into the facilities for use at the various vaccination sites. Up till the day in question, on the 30th, when I, as the immunization manager, followed up with the various regions about the stock of the vaccines, there was only one health region which still had vaccines, and that was being used at a vaccination site. No doses of vaccines were disposed of. Further to that, the COVID-19 vaccine stability studies are ongoing. And in light of that, countries who would have had expired stock are asked to save the vaccines. So there will not be a need to dispose of the vaccines, knowing very well that new vaccines such as the COVID-19 vaccine, that stability studies are going on, are still ongoing, that we would have, if we had any doses of the vaccines left, that would not have been disposed. So I just want to bring forward the point again and to make it clear that absolutely no doses of vaccines were disposed of, and that all the vaccines that we would have had in circulation were indeed used.
Thank you very much.
Okay.
Thank you. Okay. For Dr. Faswa, just something that Lucia Sharman would like clarified. She's asking that the newly announced death, the 5 newly announced deaths we had last month, were they classified as before? Were they classified as before, she said?
As before.
As before.
Well, okay. So during the process, what we did, we got death certificates. As I explained, we got all death certificates because this is what we use to do the classification of the deaths or the reclassification of the deaths, and it is based entirely on what is written by the attending physician. So at no point is the death certificate changed, but what we look at is the chronology of events leading up to the individual's death, as well as the placement of the underlying cause on these death certificates. So these 5 deaths, yes, we did get death certificates for them, and they have been classified, and as I indicated, from the breakdown, the new breakdown, they would have been included in the 85 deaths.
And I think it's important that you mentioned earlier on that out of the 85 deaths, 60 are COVID-19 deaths and 25 are COVID-19 related deaths.
Yes.
Thank you. Okay, so I don't think we have any more questions from the public or the media. So with that, we've come to the end of the press conference. I want to thank you so much for being here and for providing us with this information. Thank you.
Thank you.
On behalf of the entire production team at GIS NTN, I am Fennel Neptune. Thanks for tuning in. Until next time.